Hello everyone, I am Shubham Verma, Assistant Professor, School of Pharmacy, BBD University. Today we are going to discuss about the factor influencing the drug absorption through GIT. So first coming to the introduction. So that we all know that drug injected intravascularly directly enters into the systemic circulation and exert is pharmacological effect, and majority of drugs are given extravascularly, generally orally, if intended to act systemically. Drug can exert their pharmacological action only when they came into the blood circulation or their site of application. So absorption is the important step in the drug administration. So here you can see that the process of movement of unchained drug from site of administration to systemic circulation. So this is Tmax, Cmax concentration when drug achieve maximum concentration in body, and the time taken to attain the maximum concentration. Then this is whole is the absorption phase. Okay, this is the absorption phase. Then here it is eliminated from the body. Then coming to the factor affecting absorption. So first is the pharmaceutical factors. In that we will discuss physiochemical properties, drug solubility, particle size, polymorphism, pseudopolymorphism, salt form of drug, lipophilicity of drug, drug stability, and stereochemical nature of the drug. Next, formulation factors. So in that, disintegration, manufacturing variables, nature and type of doses, form, pharmaceutical ingredients, product age, storage condition, etc. Then some factor are also related to patient related factor. In that you can age, gastric emptying time, intestinal transit time, gastrointestinal pH, disease state, blood flow through GIT, gastrointestinal content like other food and drug and food fluid, etc. Nominal GI content, pre-systemic metabolism sometimes occur because of luminal enzymes, Catfall enzyme, bacterial enzyme, or hepatic enzyme. So first coming to the drug solubility and dissolution rate. So as we know, when we take the solid form of drug, it will get disintegrated. Okay, solid drug particle get disintegrated. After disintegration, dissolution will takes place. Okay, so next will drug in solution at absorption site. Then the permeation will occur, and drug goes into the body, like where its action is required, it goes there. So we take the drug with water. So if the drug is lipophilic, so the it is the rate determining step for the lipophilic drug. Dissolution will be the rate determining step for the lipophilic drug. And as our plasma membrane is made up of lipids, so permeation will be the rate determining step for the hydrophilic drugs. For hydrophilic drugs, dissolution is rate limited. Example of drug is aggressive fulvin, spironolactone. For hydrophilic drug, permeation is rate limited, like bromelain, sodium, and neomycin, etc. Next, coming to the particle size and effective surface area. So as we know, the smaller the drug particle, it will having the greater surface area. So there are two terms. First is absolute surface area, second is effective surface area. So absolute surface area is total surface area of the solid surface of particle, and effective surface area is the area of solid which is exposed to the dissolution medium. Next, the smaller particle, greater effective surface area, and more intimate contact between the solid surface and aqueous solid, higher dissolution will be there, so high absorption will be there. And particle size reduction has also used to increase the absorption of the large number of poorly soluble drugs such as digoxin, griseofulvin, and tolbutamide, etc. Griseofulvin has extremely low aqueous solubility, and the material for normal particle size gave rise to the poor and erratic absorption. Micro-sized particle improve absorption, but improve even more when formulated in ultra-micro-sized particle as monomolecular dispersion is propylene glycol. Next, coming to the polymorphism and amorphism. So 40% of all organic compound are exist in various polymorphic form. 70% of barbiturates and 65% of sulfonamide exhibit polymorphism. Next, amorphous form. So these amorphous form has the greater aqueous solubility than crystalline form, because the energy required to transfer a molecule from crystal lattice is greater than required for non-crystalline solid. So amorphous form of novopiosin is 10 times more soluble than its crystalline form. So very soluble is amorphous, then metastable and stable. Next, coming to the hydrates or solvates. So stereometric type of abducts where the solvent molecules are incorporated with the crystal lattice of solid are called solvates. Trapped solvent in the is the solvent of crystallization, and the solvates can exist in different crystalline form called as the pseudomorphs, and the phenomena is called pseudopolymorphism. Then when the solvent is associated with the drug in water, is the solvent is known as hydrate. Next, coming to the anhydrous form of theophylline, and so it has the high aqueous solubility and dissolve at faster rate, more viable than their monohydrate or trihydrate form. Then coming to the salt form of the drug. So at a given pH, the solubility of drug, whether basic or acidic or its salt form, is constant. While if you're considering the salt form of drug, pH of the diffusion layer is important, not the pH of the bulk of the solution. So here you can see the diffusion layer, higher pH 5 to 6, and salt of the weak acid. Diffusion of the soluble drug particles, GI lumen soluble form of the drug is there, and fine precipitate in weak acid. So their dissolution is rapid and drug in resolution across the plasma membrane. Okay. And other approaches to enhance the dissolution and absorption rate of the drug is by in situ salt formation, increasing the pH of microenvironment of drug by incorporating buffer agent, and but sometimes more soluble salt form of drug may result in poor absorption also. Okay, like the sodium salt of phenobarbital. Okay, and tablet of salt of phenobarbital as well, it does not disintegrate and dissolve slowly, so results in poor absorption. Then here is the it shows the dissolution profile of various salt like calcium, potassium, etc., and also showing the penicillin plasma concentration. Okay. these in the concentration fasting subjects with clinical trials are done, and these data is obtained from that. Then coming to drug PK and lipophilicity and GI pH partition. So pH partition theory states that the drug compound molecules with more than 100, which are primarily transported across the biomembrane by passive diffusion. So process of absorption is governed by the pKa of drug, lipid solubility of drug, and unionized drug and the pH of the absorption site. So amount of drug exists in the unionized form, and in ionized form is the function of pKa of the drug and pH of the fluid at the absorption site, and can be determined and Hasselbalch equation. Okay, so for acidic drug, pH is equal to pK plus log ionized form upon ionized, and for basic, pH is equal to pK plus log ionized or ionized. This is the formula given by the Henderson and Hasselbalch for determination of the these uh, for acidic drug and basic drug. Then it is the lipophilicity and the drug absorption. So ideal optimum absorption of drug have sufficient aqueous solubility to dissolve in fluid at absorption site, and lipid solubility is high enough to facilitate partition of the drug in the lipodal biomembrane. Drug should have perfect HLB also for optimum viability. Okay, so like for partition coefficient, you know the formula, concentration in the organic phase upon the concentration of drug in the aqueous phase. Okay, so this is all for today. Next we will discuss in the next class. Okay, thank you.